An open globe is a true eye emergency because it can lead to permanent vision loss or even loss of the eye. If you work in an urgent care, ED, or even a primary care setting, you may be the first one to see the patient. In this video, I'm going to break down what you need to know, what to do, and what to tell the on-call ophthalmologist. Let's start with a quick case. It's 8:17 at night in the ED and a trauma comes in. A 71-year-old man fell and hit his head on stairs at a barbecue earlier that day around 1 p.m. He reports left eye pain and tearing, and he can barely open his eye from the swelling, and when he does, he says he can barely see anything but light. And his glasses don't help his vision, so he has light perception visual acuity. His right eye is unaffected, and as far as his ocular history, it's notable for uncomplicated cataract surgery in both eyes 4 years ago. The CT orbits without contrast and thin cuts shows a deformed left globe. An open globe injury is a full thickness wound to the outer layers of the eye, specifically the clear cornea, the white sclera, or both, and is most commonly due to trauma. So the eye is literally open. It's a true eye emergency with risk of permanent vision loss, infection, and even globe loss, that's loss of the eye. It requires urgent surgical repair, ideally within 24 hours from the time of injury, not the time that the patient arrived at the ED or urgent care. And that distinction matters. Let's say a patient fell in the middle of the night going to the bathroom, and maybe at the time they don't realize the severity of the injury until the next morning. By the time they're seen in the ED, it's 10 hours after the time of injury. So now there's 14 hours instead of 24 to try to get the patient in the OR with an ophthalmologist. So it's really important to know the time of injury, especially if you're going to have to transfer the patient to get them to a facility that has ophthalmology. A quick note on terminology. Open globe is the umbrella term, and there are two main categories based on the mechanism. The first is a rupture. So you may hear the term globe rupture, and this happens from blunt trauma. A blunt force can compress the eye, the intraocular pressure spikes rapidly, and the eye wall gives way. Usually at a weak point, like where the extraocular muscle is attached to the white sclera or a prior surgical incision site. And that may or may not be where the actual impact occurred. Think of it as an inside-out mechanism. The second category is a laceration. This is from a sharp object or projectile creating an outside-in wound. Lacerations are further divided into three subtypes: penetrating, where there's one entry wound and the object does not exit; perforating, there's an entrance and exit wound through the globe; an intraocular foreign body, a penetrating wound with a retained foreign body inside the eye. For the purposes of ED management, what matters the most is recognizing that there's a full thickness wound, protecting the eye, and getting the patient to an ophthalmologist as soon as possible. It's good to be aware of the different types of an open globe, but using the term open globe when talking to an ophthalmologist is fine. So what causes these injuries? Some examples include blunt trauma like falls, assaults, motor vehicle accidents with airbag deployment, a finger poke injury like in basketball, high velocity projectiles, gunshots, BB guns, nail guns, or even paintball guns, sharp penetrating objects like metal fragments, glass, for example, if a windshield shatters in a car accident, stabbing, sticks, tree branches, blast or explosion injuries. Here's an important clinical pearl. A patient who's had prior eye surgery like cataract surgery, corneal transplant, LASIK, has a structurally weaker globe at the prior incision sites, which is why the patient's prior cataract surgery, in the case that we started this video with, is important to make note of. Corneal incisions in cataract surgery generally heal well, but they don't quite fully regain the same strength of a native cornea, so it's important to make note of, especially in ocular trauma. Let's move on to signs and symptoms. An open globe can range from being obvious to subtle. Here's what to look for. Decreased visual acuity, and it's often significantly reduced to hand motion or light perception, but it can also be only minimally decreased or even 20/20, especially if there's a small self-sealing corneal laceration outside of the visual axis. If I get a call and I'm told there's concern for an open globe, I'm anticipating some degree of vision loss. And I'm not surprised if it's significant. Let's say a patient's visual acuity at baseline is 20/30, maybe now they're 2400. If the visual acuity is 20/20, that is reassuring. It's telling me that the eye is still functioning, but it doesn't rule out an open globe. It makes it less likely, but it could also mean that the injury is small and hasn't affected the visual pathway yet. So the visual acuity is really important, but a normal visual visual acuity 20/20 or a patient being at their baseline does not rule out an open globe. Other things to look for on exam: a pupil abnormality like a peaked or teardrop shaped pupil, those are classic, but the pupil can also look completely normal in an open globe. A relative afferent pupillary defect or RAPD, a globe deformity on exam or imaging, visible intraocular contents extruding outside of the eye like uveal or vitreous prolapse, a foreign body sticking out of the eye, anterior chamber abnormality, which can be shallow, flat where the iris is pressed against the cornea, or abnormally deep. So here magnification helps, but if you don't have a slit lamp, you can use a pen light and compare the anterior chamber depth of the injured eye to the uninjured eye. The goal is looking for a difference. Also look for a hyphema, that's blood in the anterior chamber, or vitreous hemorrhage. Eyelid edema, chemosis, clues that the eye sustained a lot of force. And this one is important. A 360 or near 360 degree bullous subconjunctival hemorrhage. A subconjunctival hemorrhage on its own that's flat, asymptomatic, and there's no vision changes, that's usually benign. But in the setting of trauma, a subconjunctival hemorrhage that is bullous or elevated and extends 360 degrees or near 360 degrees around the eye tells you that the globe sustained a significant force, and that blood may be hiding a scleral laceration. Treat this as an open globe until proven otherwise. You also want to look for a positive Seidel test, which is a quick diagnostic test that's done at bedside, and it's used to detect leakage of aqueous humor from the eye, which is a clue of a full thickness wound. Here's how it's done. Place a numbing drop on the eye, proparacaine or tetracaine. There we go. Then the fluorescein. I prefer using the sodium fluorescein strips because you have more control over where you place the dye and how much. Imagine this is the lower lid down, pull it gently. You want to make sure you're not putting any pressure on the eye. So you're going to pull down the lower lid. So my finger here is resting on my bone. Pulling the lower lid down and then just gently painting. So it kind of looks like this, just kind of gently painting the back side of the lower lid. And then if the patient's able to blink for themselves, I have them blink, 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 or I will very carefully move the lid to blink for them. But again, you got to do that very, very cautiously. So you can do that to start to kind of get a general sense of what's going on. And then if there is concern that, let's say there's a corneal laceration, the other thing that you can do is very gently paint the dye directly over the area of concern and then examine the eye with a cobalt blue light from a slit lamp, the Woods lamp, indirect ophthalmoscope, a direct ophthalmoscope, or even an app. And if you want to know an app that I've used before, check out the link in the bio. I'll put an example app that I've used, especially if I have limited access to certain equipment. After putting the sodium fluorescein dye on the eye, as you're shining that cobalt blue light, what you're looking for is a darker colored stream of fluid that looks like a waterfall. It briefly goes away when the patient blinks and then it comes back. So that's a positive Seidel test. And here's a tip. If you're not sure whether what you're seeing is an active flow of aqueous humor or something else like mucus, have the patient blink a couple of times to spread the fluorescein to see if you can reproduce the flowing stream or if it just gets blinked away. It's important to know that a negative Seidel test does not definitively rule out an open globe. It lowers the likelihood, but a faux thickness wound could be self-sealing or plugged by iris tissue or vitreous. And if aqueous humor isn't actively leaking, the anterior chamber may actually be formed and look normal. For example, let's say someone was at work and felt like something hit them in the eye, and you're able to tell that there's a foreign body in the anterior chamber, but everything looks fine. Can't really tell if there's a corneal laceration, see maybe a corneal abrasion, but the test is Seidel negative, patient's visual acuity is 20/20. So is that an open globe? Well, yes, because how else did the foreign body get into the eye? Even if the door looks temporarily closed, it may just be a swinging door that, given enough pressure, it's going to reopen. So the key takeaway for the Seidel test, it's an important part of examining a potential open globe, especially in trauma, but you cannot solely rely on it. Also, it's important to note that if there's an obvious open globe, defer the Seidel test. At that point, there really isn't a need, and any unnecessary manipulation of the eye is contraindicated. All right, let's talk about management. Here's what to do. Examine both eyes. I know that probably sounds obvious, but even if a trauma appears to only involve one eye, make sure to examine both eyes. You just never know. And this applies to any time you're seeing an eye patient. Also, ask the patient if they were wearing glasses or contact lenses at the time of injury. Glasses can shatter on impact, and a piece of glass or plastic could have penetrated the eye, or small fragments could be hiding behind an eyelid. A quick comment about contact lenses. In general, contact lenses that the patient wears routinely should be removed for an eye exam. You want to be able to get a good look at the eye, and because the fluorescein can also permanently stain the contact lens. But if there's concern for an open globe, err on the side of caution. Don't remove that contact lens. A contact lens overlying a wound could be adherent to prolapsed tissue. So in trying to remove a contact lens, that could risk pulling on that prolapsed tissue. So instead, let the ophthalmologist know that there's a contact lens on the eye. If there's enough concern for an open globe, immediately place a rigid, dome-shaped eye shield over the affected eye, like a clear eye shield or a Fox shield, a metal Fox shield. You place it over the eye with tape. Now, if you want to see exactly how to do it, be sure to check out the link that's down below. And the purpose of this is to protect the eye from further injury. The shield protects without compressing, and it signals to everyone, leave the eye alone. Don't touch it unless the ophthalmologist has instructed to put eye drops. It is a visual reminder to the patient, to everybody, that there is a problem, leave the eye alone. Now, you don't want to put anything directly on the eye, because any pressure on an open globe could expulse intraocular contents, and that can significantly worsen the injury. So don't patch the eye, don't put gauze on the eye. That's why that clear dome-shaped eye shield is important. All right, so after the exam, you have enough concern for an open globe. There's an eye shield over the affected eye. Make the patient NPO. Open globes often go straight to the OR under general anesthesia. The moment there's any possibility of an open globe, even if you haven't seen the patient yet, but you heard the mechanism of injury and it sounds concerning like a stabbing, make the patient NPO. Remember, the goal is urgent surgery within 24 hours from the time of injury. All right, other things to do: order a CT orbits without contrast. And this part is important, with thin cuts. The eye in the orbit is very delicate, and if the cuts are too big, a small little foreign body or even a scleral laceration could be missed. I recommend adding to the radiology order to make the cuts as thin as possible, like 0.5 to 0.6 millimeters if possible. An open globe is a clinical diagnosis, but imaging is a useful tool, and it's also important to rule out an intraocular or intraorbital foreign body before heading to the OR. Also, consider starting broad-spectrum IV antibiotics. Ocular trauma is a risk factor for endophthalmitis, which is a vision-threatening infection inside the eye. If the open globe is obvious, there are no significant contraindications, and the benefits clearly outweigh the risks, start antibiotics even if you haven't spoken to ophthalmology yet. The earlier, the better. A commonly used regimen is IV vancomycin, 15 milligrams per kilograms every 12 hours, with IV ceftazidime, 50 milligrams per kilograms every 8 hours, with renal dose adjustments when indicated. If there's a penicillin or cephalosporin allergy, IV moxifloxacin 400 milligrams is an alternative. If you're not sure if the globe is truly open, but you have enough concern about the possibility, you can consider starting topical moxifloxacin eye drops, or Vigomox, every hour to the affected eye, and hold on the IV antibiotics until you speak with ophthalmology. Just make sure that whoever's going to be instilling the eye drops, that they put no pressure on the eye whatsoever. In addition to antibiotics, update tetanus if indicated, control pain and nausea for patient comfort, because you don't want vomiting or straining to lead to a rise in intraocular pressure, which could expulse intraocular contents through an open wound. And counsel the patient to avoid Valsalva maneuvers for the same reason. Basically, tell the patient to take it easy. Don't talk loudly, try not to laugh, nothing that's going to really increase the pressure. As far as activity restrictions, bed rest with assisted bathroom privileges to avoid further trauma. If the injured eye has significant vision loss, the patient's depth perception may also be affected, so they could be a fall risk. And elevate the head to about 45 degrees unless it's medically contraindicated. This can help with any swelling and lets blood settle. What not to do? Now, I'm going to belabor this point because it is critical. Do not apply any pressure to the eye, and this includes tonometry. Anytime there's concern for an open globe, defer the eye pressure check. This also includes the ultrasound, so defer POCUS. Applying a probe to the eye, even with gel and a light touch, creates direct pressure, and it's not worth the risk. Instead, use the CT as your adjunctive tool. If there's a foreign body penetrating the eye, don't remove it. Shield the eye as long as the shield doesn't put any pressure on the foreign body, and let ophthalmology handle it in the OR. If you see what looks like clear mucus, don't wipe it away. It could be vitreous that prolapsed out of the eye. Vitreous is attached to the retina, so pulling on it could pull on retina. retina, and you don't want to do that. If the patient requires intubation, avoid succinylcholine when possible. Succinylcholine is a depolarizing neuromuscular blocking agent. It causes the extraocular muscles to contract, which can raise intraocular pressure and risk expulsion of intraocular contents. We've done the exam, the Seidel test is positive, got the CT, it's concerning. You're at a point where you are very concerned about an open globe. Call ophthalmology immediately. And this is day or night, whether it's a holiday, weekend, or a Tuesday. But before you call, have this information ready and relay it to the on-call ophthalmologist. And don't worry about writing all of this down. I put together a downloadable PDF that's gonna have this information as well as a summary of the content in this video. So just relax and then grab that PDF whenever you want. Mechanism of trauma, time of injury, exam of both eyes, glasses or contact lens status, CT imaging results if available, clinical photos if possible. External photographs are very helpful in any ophthalmology case. NPO status, whether IV antibiotics were started, if a protective shield has been placed in the affected eye, ocular history, whether they've had a prior eye surgery or trauma and when that was, current eye diagnoses and medications. And it's also helpful to relay whether the patient sustained other injuries that will need repair by other teams like trauma surgery, plastics, or orthopedics, because that helps with OR planning. So now you know what to do, what to look out for, and what to tell the on-call ophthalmologist. Do me a favor, share this video with a colleague, somebody that you've trained with, someone that you're training with right now so we can keep simplifying ophthalmology, and check out this video next.